In this consultation, the patient is Mr. Michael Watkins, who has a long history of myeloma. Was originally diagnosed over 5 years ago, and his initial treatment with CTD wasn't tremendously successful, but he subsequently responded well to bortezomib and had an autologous stem cell transplant. When the disease progressed again, he had lenalidomide, but the disease is now progressing once more, and the paraprotein is rising about 5 grams a month. The current level is about 40 grams per litre. His renal function is impaired but stable, and he's come for a routine clinic visit to see Dr. Graham Jackson, who unfortunately knows that since his last clinic visit, there are some fresh lytic lesions in the bones of his pelvis. Normally he comes with his wife, but she hasn't come with him today because of family commitments elsewhere. And the discussion is going to hinge around the fact that Dr. Jackson feels that at this stage his treatment options are very limited.
Michael, how are you doing?
Not too bad, thanks. Yes.
How has the last month been since your last course of treatment?
Yeah, it's all right.
Have you noticed any new problems, anything that's changed?
No, I don't think so. You know, I still get a bit tired. I get a bit pleased to see my bed in the evening.
Yeah. Okay. Michael, I know you know a lot now about myeloma, and we've been watching your progress on the Revlimid, and as you know, when you started, you were doing fantastically well.
Yeah.
I have to say, though, that the last few paraprotein readings have been worrying me. The protein level is starting to rise,
Right.
which suggests that although you're still taking the Revlimid, it is no longer holding your disease, it's no longer controlling the myeloma.
Mm-hmm. Right. So
It means that probably we need to stop the Revlimid because it's no longer working. Now, you know you've been on a number of different treatments,
Yeah.
but there's no point us continuing the Revlimid if it's not holding your disease anymore.
is it? I mean, not even. It wouldn't get worse quicker if I come off it.
No, it's progressing despite the Revlimid, so I don't think, all I think we're doing with the Revlimid is possibly giving you side effects of the treatment without helping you.
Because I mean, I'm not noticing any great difference.
No, but and that's often the case, that the protein levels start to go up before you start to get into some problems. And I have been concerned about you, and that's why we did the x-rays the other week, and that also shows that there is some new bone problems that haven't been there before. So all this points to your disease being active even whilst you're on the Revlimid therapy.
Right.
Now, we've known each other a long time, and I have to tell you that this isn't good news, obviously.
I can tell from the tone of your voice.
Yeah.
So is there something else you can give me, or some other road we can take?
Well, you've been through a lot of the best treatments we can offer, and as you know, you've had a lot of different therapies over the last few years that we've known each other. Yeah. I'd have to say that because of a number of other things that are going on with you, we can't really enter you into a clinical trial of any new drugs. So there are things we can do.
Sorry, when you say a number of other things that are going on.
Well, you know, to get into a clinical trial, you have to fulfil a lot of different important criteria, and because of where you're at in your disease and some of the problems you've had before, you wouldn't really be eligible to go into those clinical trials, I'm afraid. So when you say, is there things we can do? Yeah, of course there are things we can do to try and help you, and that remains my job. But I have to tell you that failing on the Revlimid after all the other treatments that you've been on, it's going to be very difficult to keep your disease controlled.
You're saying there's nothing else you can go back to or move me on to?
I'm saying there are things we can do, but your disease is now proving to be very difficult to control.
I'm trying to get
I know.
get myself clear about. So you haven't got another.
We haven't got a lot of fantastic treatments I can offer you. You know that you've been through 4 or 5 different courses of treatment now, and we know that you're resistant, or your disease is resistant to a lot of these treatments.
Yeah, it is now. Yes.
So
There must be something else. I mean, there are. This is supposed to be one of the areas of medicine where things are improving all the time.
There have been a lot of improvements, but I have to say at this stage, Michael, there's not a lot of therapy we can offer that is really going to make a big difference to you.
So there's nothing else that's going to significantly stop it.
I think you're in a bad place with your disease, yes. We're in a situation where I obviously going to keep looking after you, but I'd have to say, Michael, your myeloma is behaving now very, very aggressively. And I haven't got the tools to really stop a lot of the progression. So yes, you're in a bad place.
I know you said I couldn't get onto clinical trial. I mean, you're sure about that?
Yeah, I've looked, Michael. I've checked that out before we had this conversation, because I didn't want to come into this conversation without knowing if there was another option that I could offer it to you. But I've checked, and sadly, there is nothing in terms of clinical trials I can offer you. But that doesn't mean that I'm going to stop looking after you. We need to look after you. But you're in a bad place.
Yeah. Basically, you're saying you can't control the disease, so the disease is now going to take its course.
That is what I'm saying. I'm going to do everything I can to try and hold on to the disease, but I think if we would have to say that you're now at a stage where your disease is terminal. I'm afraid. I'm really sorry. I'm really sorry.
Well, there must be some other things that are worth a try. I was looking the other day. Have you read this stuff that they're doing at the Mayo Clinic?
I have read some of that stuff.
Cheetacin? I think it's pronounced I don't know. They've got extraordinary results with that apparently some of the time.
Michael, that's a very experimental thing, and it's not really in patients in your situation.
I'm prepared to be very experimental.
I know you are.
I mean, I don't care. What are you saying? Experimental? It's a risk.
No,
it's a risk now where I am.
What I'm saying to you is that I haven't got an experiment to offer you. I know you would do anything.
Well, it's not a good time to leave Margaret. I mean, I shall go and check on this. I mean, I'm not disputing what you're saying, but you're a conventional doctor.
I am.
And I can't believe there's nothing else one can do.
Okay, I hear what you're saying. And I'm not saying there isn't things I can do. I'm just saying that realistically, whatever we do with the tools that we have left, we're not going to be able to control your disease for very long.
Right, for very long. How long?
I don't know. Impossible to say, but we're not talking about years. We're talking about months, and maybe not many months. I'm really sorry. And I realise that Margaret's not here today.
No, that's all right. That's all right. It's better she's not, probably.
Well, I think probably it would be worth me meeting with you and Margaret as well. I don't know what you think.
Anna's going to have another baby in July.
Okay, well, that's very important, so we have to do everything we can to
Hang
make
on
sure
for that one.
Well, it's my job to help you do that. and an
I
important.
can't. Sorry. I don't know. I can't get my head around it.
I'm so sorry. I know
It's going so well.
you
Yeah.
were. You're doing fantastically, but I'd be lying if I said you were still doing well.
Sorry, I'm very silly.
Just take
Very
your time.
silly.
Not silly at all.
Of course it is.
Not silly at all.
You kind of know it's coming, but we've put it off for so long.
I know we know each other so well, and I know we've been through so much together, and I really didn't want to come into this conversation without knowing that I hadn't explored every avenue that might be possible for you. But you were on treatment, you've responded to, but your disease is now progressing through that. You've had lots and lots of treatment before.
No more chemo, no more.
Well, there are things we can do. We might use some steroids, we might use some radiotherapy for some of the points where your bones might have some problems.
Right.
So we don't stop looking after you. But what I'm telling you is that I can't achieve a great deal. But I will do the best I can.
Okay. I just... It just seems so ridiculous when, most of the drugs have worked really well. Not all of them, but
Yes, they will.
why do they stop working? I don't know. No, it's probably a long, complicated answer, and I don't really want to hear it, but it just doesn't make any sense to me.
Okay. Well, there is a long and complicated answer, but often the cancer cells are very good at escaping, becoming resistant. A little bit like antibiotics stop working in some infections.
Yeah.
Eventually, the cancer cells are very clever, and if you expose them to drugs for long enough, they learn new ways of avoiding being killed by the treatments we're giving you. And that's why we know that you're in such a bad place, because you've gradually got resistant to every treatment we've tried. So sadly we know that the cells in you would laugh off any treatment. Any treatment we tried to give you, we'd probably give you more side effects than we would help you, if that makes sense.
And they wouldn't slow it down. Well,
No. We'd be giving you it so that I could write a prescription and feel better about writing a prescription, and you could take some tablets and feel better about taking some tablets, but it would be a lie.
fair enough. I don't quite know how to go home and tell Margaret.
Okay. Well, I'd be very happy to see Margaret, and if you wanted, I'd be very happy to talk to her and do that for you. If you wanted to bring her in, just say Dr. Jackson needs to see us both, he's asked us to come in, and I could do that for you. Or if you tell her, I'm happy to see you both and speak to Margaret about what we've discussed.
Yeah.
You tell me what's the best for you.
I'll have to ring you or something. I can't at the moment. I need to go somewhere.
Okay. Well, you can stay here. We can get you a cup of tea and you can stay here for 5 minutes. You don't have to rush off. Don't go out into the waiting room. Stay here. I can go and get another consultation room. We can get Sarah to come in and talk to you. And, she can sit with you a while. Sarah, the nurse, you know so well.
Nice. Yeah, no, Sarah.
Yeah.
I know. I just... sorry, this is out of the blue. I wasn't expecting this
I know.
at all.
And I'm sorry.
I'm sorry, I'm behaving very foolishly.
Not at all.
It's just... This has been such a long sort of thing, and you keep thinking, no, I know in the end you can't get away from it.
But you put it to the back of your mind.
Hmm.
And you dare to hope that you're going to do well.
Yeah, well, we're going to have another holiday later this year.
Yeah, I was glad you booked that, but I'm sorry that obviously that's going to be difficult.
Yeah, it won't be summer, I think.
I don't know. I really don't know, Michael. It's my job to... If I can get you to that holiday and you can enjoy it, I would be delighted, but I don't know.
Maybe we'll do something at Easter. I might still be on my feet at Easter.
Yeah. But I don't know.
You don't know about Easter?
No.
Right. Okay. Thank you. Don't stop looking for other things, will you? I'll do anything. I will do anything.
I know.
I don't care if it's high risk, because this is high risk, isn't it?
Yeah.
Thank you. Thank you very much.
Do I go and get you that cup of tea now?
Yeah. Yes, please.
And if you want me to speak to Margaret, I'd be happy to do so.
I'm not sure at the moment. As I say, I'll tell you. I can't.
Yeah, you judge it. You tell me
She's
what
not-
you want me
I
to
mean,
do.
I go home today, she's not expecting this. She's just looking after the grandchildren. She won't be home till about 7.
Okay, so what are you going to do now?
Have a cup of tea. I
Yeah.
don't know after that.
Okay.
Don't know.
As I say,
Thank you very much.
Stay. You don't have to rush out. Have a cup of tea. Stay in here.
Mm.
I'll get Sarah to come in and have a chat as well. And
Well,
then I can come back and talk as well.
What's going to? I mean, it's going to get painful, isn't it?
I hope not. I think I would be. Of course, there may be some discomfort, but again, part of my job is to make sure your pain is well controlled, and we might have to involve the Macmillan team and make sure that all of your symptoms are looked after. So you may get some pain, but our job would be to look after that.
Okay.
You may need a blood transfusion. You may get infections. The important thing is we don't stop looking after you.
No.
Even though we're not treating your disease,
Thank you.
or we know that treating it is not going to achieve a great deal.
Right. Thank you very much. Thanks for everything.
Graham, that was obviously a very tough conversation. Tell me about the business of telling bad news to patients that you know well.
It's always very, very difficult, and there's part of you that wants to avoid having that conversation. I think you often get to a situation where you think, I could offer him something else just to avoid having this conversation. I could live the lie, write the prescription, give it to him, and we'd both collude in saying that things were going fine. But I think you need to be honest.
Yeah.
And Michael obviously pushed me very hard about what else I could do and that there must be something else. And obviously in this particular situation there wasn't.
Yeah.
And you have to, I think, be straight.
Yeah.
As difficult as that is. And as I say, I think the easy option sometimes in that situation is to just say, yes, there is something else. That would be easier for me to say than to go through that.
Yeah.
I think that's always the danger, especially with someone you know well, which obviously you have a long relationship with, Michael.
And like me, with patients you know well, you're on first name terms with him.
Yes. And I think you get to know these patients, Michael and Margaret, very, very well. You know about their grandchildren, you've seen them. I knew about the holiday he had booked. You have a feel for where their lives are at. And quite clearly that makes telling that news difficult, and something there is a little part of you that's trying to avoid doing it. Yeah.
And actually maybe, and I don't want to be critical about this, if you were honest, you avoided this conversation a month ago.
Yeah, because you hoped that the last 2 paraproteins were a blip. Yeah. So and when you do that is your timing, because often the patient will know the results only from you, although some patients like to know their protein results. So we might have had this conversation a month ago if Michael had been following his results, and the timing is not always easy to judge.
No. You saw him in the routine clinic without his wife, and you made, I think, an entirely appropriate offer to see him with Margaret. Would you have, if you'd known he wasn't coming with Margaret today, would you have planned it differently?
That's a really good question, and I think ideally it would have been better if Margaret had been here, and you would have probably had your nurse specialist with you. But if you suggest he brings Margaret, you're sending
the moment your secretary phones him and says, "Will you bring Margaret with you to the next clinic appointment?"
Yeah, he then has 7 days wondering, or 2 days, or a day wondering what that's all about, and also he may not wanted
To
to
have that
bring Margaret,
conversation,
and that was one of the things we touched on. You wondered whether he was almost happier that we'd had this personally rather than with Margaret being present.
Yeah.
But you have to give so stage managing is sometimes not always easy, I think.
No.
And that's why I gave him the offer to come back with Margaret.
Well, I think that's a cue for me to turn to you, Michael, and ask you about those things. Would you rather have had Margaret with you?
No, I think today was better just getting the news myself, because it was such a shock for me, and would have been just as much of a shock and more so for her. And I think I can, having absorbed the shock myself, I'll be able to manage.
Yeah. And you're
Better.
probably the best judge of that particular dynamic.
I think so. I'm not quite sure what I'll tell her tonight yet, but I will tell her.
In the context of this really dreadful conversation, what was the best thing that Graham did for you?
We did a lot of things, but he most importantly kept saying, just because we can't necessarily control the disease, we're not going to stop treating you and looking after you. And looking after, I think he used several times.
Yeah.
So that was very important, and he was very honest, which at this point was the only thing. And he was also very clear about, I mean, it sounds terrible to say, he sort of killed off any hope in a way, but he made it clear that, that I couldn't sort of carry on clinging falsely,
No.
which is probably going to be better for me over the next week or two than having, oh well, maybe there's something, But it was the fact that he promised to look after me, and it was going to be him who was going to continue to look after me. That was important, because we know each other pretty well, and I trust him completely.
Good. Okay, thank you both.